Day surgery for hip and knee replacements. How did we get here? Used to be 7 days, now all of a sudden it's same day. Welcome to Talking with Docs. I'm Dr. Brad Wynn.
And I'm Dr. Paul Zalza. So what are we talking about here? We're talking about
People that have big operation, a knee or hip replacement, and they go home that same day.
how can that be?
Because 20 years ago when we started, it was like 5 days, I'd say was the standard. And in residency, sometimes people were coming in the night before, maybe 2 days before, having a bunch of stuff done, and then staying 5 to 7 days.
Then it went down to about 3 days.
Trickled, yeah, and then 2.
And then I remember overnight, tried to get people home the next day.
Yeah.
And here we are now.
And I'd say at our hospital now, our goal is that 100% of people are going home on the same day. I'd say there's a very small group of people who are not candidates, and that would include people with severe sleep apnea, people that have really elevated BMIs or complicated comorbid disease, or don't have adequate home support.
Right. And if you've heard about this and thought, no way, this is crazy, that's what I thought too.
Yeah, so we were late adopters at our hospital, full disclosure.
Yeah, I was against it in the beginning, but now I realize that, hey, it's a good thing.
Okay, so leave a comment if you had day surgery, didn't have day surgery, love it, hate it, whatever. Leave a comment. There's lots of people getting ready for surgery and they're wondering, how am I going to get through this? So we're gonna go through all the reasons why we think we got here, how we got here, why it's a practical, sensible, successful solution in modern times.
And why it's safe, because that's the main thing that you're worried about.
Of course, and that's what we cared about. That's why we were slow to adopt.
Yeah.
So I'd say the first thing is, before surgery, people get way more education.
Yeah.
So they're told what to expect, they see a physiotherapist, they learn the exercises, and we always preach this before, even before this was a thing. Learn the exercises so you don't have to learn them afterwards. And then they're told kind of what to expect so that they can plan their home.
We should
have a plan.
We should write a book and call it What to Expect When You're Replacing.
Oh yeah, I like the what to expect when you're expecting.
See what I did there?
Yeah.
So yeah, that's the big thing. One of the biggest parts is pre-operative education.
Okay, so that's the before. What about the during? So you're at the hospital now.
At the hospital, during, the biggest thing that I think has contributed to the ability to send people home the same day is changes in anesthetic practices.
Wait a sec, don't tell the anesthetist that they get all the credit for us being better at our jobs.
I think it is, and I think it is. And the problem with it is it takes them a long time to do all those things that they need to do. So
right. That was especially at the beginning, was a logistical challenge.
It's getting better now.
Sure.
In some hospitals, it still takes a long time to get all those things done.
Okay.
In other hospitals, they can do it very smoothly and efficiently, but the anesthetist is doing different things.
Okay, so with the first thing is, I would say, like historically over decades, is that we transitioned from a general anesthetic to a spinal anesthetic. So general anesthetics, people were groggy, they were nauseous, it took a long time to recover. Right. So spinal anesthetics, or a regional anesthetic where your legs are frozen, this is an easier way for you to get better faster.
Right. A general anesthetic, you're completely asleep, you can't even breathe on your own, you have a tube down your throat to breathe for you, and then that take some heavy-duty medications, systemic medications that knock you right out, and then time to wake up. And there are some side effects of that: nausea, vomiting, slow to wake up, grogginess, like you said.
Right. Specifically with respect to the spinal, I'd say that even that has changed in that now they use lower doses of freezing, so your legs come back faster. They use lower or no doses of narcotics, so that makes you feel less groggy, less nauseous, and also reduces your risk of urinary retention, which was a big obstacle before.
Yes, because I remember when everyone got a catheter before their joint replacement. Everyone got a urinary catheter before joint replacement. That certainly makes it more difficult to go home if you've got a catheter. So
other things about the anesthetic, I'd say additional blocks that we do in addition to the spinal anesthetic. So sometimes it could be an injection in your groin or in the back of your knee, and it may even include a catheter that trickles out local anesthetic even for a day or two that you may go home with. So these have all drastically reduced the amount of pain that you have, allowing you to get better faster, but it doesn't affect your muscle function, so you can still get up and walk.
Okay, so evolution of anesthetic and anesthesia.
Agreed.
And that's really what helped surgery way back hundreds of years ago, was the development of anesthesia. We could not do surgery without appropriate anesthesia.
Ether.
So that is that is continuing to evolve, and that's what's enabling people to go home quicker. And survive more than they did 200 years ago.
There you go. Okay, so that takes care of the anesthetic part. What about the intraoperative part? What about the surgery part?
So the surgery part, I think...
Are you way better than you were 20 years ago?
I don't think that has changed as much as the anesthetic, perhaps subtly. You've heard of minimally invasive procedures and things. Now we just sort of generally are more cognizant of the fact that we're going to try and send this patient home. And certainly blood loss is reduced, or at least the trigger to transfuse has changed. We used to transfuse blood more readily, which is another reason you would stay in the hospital for a blood transfusion. Now it's extremely rare to get a blood transfusion.
And there are medications that help reduce the amount of bleeding during surgery, which I would say is a game changer.
Yes.
I'd say also during the OR, we no longer, because of the bleeding, we don't usually use drains. When I'd say in training, a lot of times we use drains, so people had to have their drains monitored. You had to wait a day or two to pull the drain, so it was one more obstacle to getting people home. You had to get rid of the catheter, get rid of the drain, get them up.
Yeah, a drain is something you leave in the wound, in the surgical wound, drain to a reservoir that just drains blood out as you stop bleeding.
Yeah.
Made sense 20 years ago. 25 years ago.
But yeah, surgery-wise, I'd say even with people like, oh, I'm getting robotic-assisted surgery, it's going to be way better for me. Like, I think it improves the accuracy of the operation. I don't think it's going to get you home any sooner or moving any faster.
Okay, so mostly anesthesia changes, minimal
a little bit of surgery stuff. Okay, what about when you're getting ready to go home? I'd say the other thing is early mobilization, right? So we're getting people up like 3 hours or 4 hours after they've had a big operation.
Yeah, even sooner. They're getting up fast. So that's a team approach where we have a physiotherapist coming down, possibly an occupational therapist to assess. Or the occupational therapist will get involved in the beginning to see if your home situation is appropriate. But yeah, physiotherapists coming down to mobilize you shortly after your surgery.
Right. What about medications post-operatively? Just give them just narcotics and send them on their way?
Right. We have now multimodal approaches to pain control. So it's not just one agent that's going to reduce your pain. You may have some narcotics, some anti-inflammatory, a nerve-acting agent, acetaminophen.
Maybe a topical.
Maybe a topical.
Yep.
A collection of medications to help deal with your pain, because that's another barrier to going home. It's pain control.
Yep. I'd say the other barrier for me used to be antibiotics. We used to believe that you needed 24 to 48 hours of intravenous antibiotics. Now, because it's what's called a clean procedure, some people would argue maybe you need 0 doses afterwards, maybe 1, maybe 2. Certainly the maximum would be 24 hours, but that is very debatable, and it's certainly trending towards way less antibiotics.
The pre-operative dose of antibiotic is under debate now, too.
Yeah. Pretty soon we won't even wash our hands. We'll just go in there and just
I think we'll get to that.
I'm just joking.
Do it. We're gonna come to your house and do the surgery.
That's right.
Drive through in your garage.
I'd say the other thing in the post-operative phase that has improved pain reduction, which facilitates people getting home sooner, is the cooling unit. Like I think in the last kind of 5 years, this has become almost standard of care. I think if you have the means or access, definitely you should pursue one. Just cycling the ice cold water rather than just a bag of peas has been way better.
Back to that RICE protocol.
Yes.
Rest, ice, compression, elevation. So we just basically put ice on your wound, cooling it down to minimize the inflammation and thereby minimizing the pain and the swelling.
Right, so then patients are gonna say, well, I see that this is good for the hospital, right? Because you're getting people home sooner, so you don't have that burden of care, which definitely is. Which definitely is good, because it allows the hospital to be filled with sick people, not post-operative people.
You know what? Who's kidding you? That's a real benefit to a system.
100%.
Is reducing the cost of healthcare.
And I'd say the impetus for this actually came during the pandemic. When they said, we don't have any beds for these people, so if you think you can operate and get this person home same day, then you're allowed to do it. So it kind of,
we're not claiming
necessity is the mother of invention.
We're not claiming that this was designed entirely with the patient in mind.
No.
It was not. It came from a place where we had to cut costs in the hospital.
100%. But what I would say for you as a patient, you're like, well, isn't it better if I stay in the hospital if I could pay, or if there was some other way? I would say no.
And famous old saying, nope.
Nope. Yeah, so one, you get to avoid the risk of exposure to things that live in the hospital, and those are hospital-acquired infections. They're uncommon, thankfully, but they're potentially real and potentially very aggressive. You get to be at your own home. So you get to sleep in your own bed, eat your own food, be surrounded by your loved ones, be in a familiar environment where you're gonna be less confused, and have an appropriate level of care, because healthcare systems are taxed, so you don't always have enough people just to pay attention to you when you need it. So this has actually turned out to be very good for the patient. I think there were some growing pains, but I'm a big believer now.
So, but we're not saying, oh, it's, the hospital's not benefiting. The hospital is, the healthcare system is benefiting. But remember, if the healthcare system, if you're in a publicly funded healthcare system, and the healthcare system is benefiting, then you are benefiting, because when you need the healthcare system, it'll be more available.
And I'd say the money that's being saved is just being diverted to other necessary healthcare issues. It's not like it's paying for parties for the surgeons over the holidays.
Is it?
No.
Yeah, right. So no one's pocketing this money. In our publicly funded system, it's going back into the system.
Yeah.
And having said all that, the other big thing that the hospital does do, or should do in your area, and ours does, is you have access to help.
Oh, a really big one.
There's like a 24/7 phone number you can call if something's going on when you're at home and you feel like, oh my God, what should I do? You can call and get advice.
Yeah, my pain's out of control. I think my leg's infected. I think I have a blood clot, whatever.
Yeah, and Once you leave the hospital, it doesn't mean you can never come back. If you
No.
go home and you have a problem or any issue, you just come right back to the emergency room.
Right. Open door policy.
Right? And at the end of the day, what would you prefer if you had to have a joint replacement?
I would want to go home the same day.
I'm the same. I'd want to
Yeah.
go home the same day.
Yeah.
There's just, you don't want to be in the hospital.
But
longer than
1
you have
year
to be.
ago, I would have said I would like to stay one night.
Yeah.
Yeah, like I was,
Yeah.
I was slow
It's
to
evolved.
because I was worried. I was worried bad stuff was going to happen.
Mm-hmm.
And what's nice is now that hundreds of thousands of people throughout the world have had day surgery hip and knee replacements, and it's been proven that there's no increased risk.
And I mean, bad things can happen
Of
with
course.
surgery, right? Heart attack, stroke, death, blood clot, infection.
But being at home doesn't
pneumonia.
protect you from that necessarily.
Yeah, that 1 day in the hospital or that
Yeah.
2 days in the hospital is not going to reduce that risk of something bad happening.
Yep.
Okay. And going home the same day is not going to elevate that risk of something bad happening.
Agreed. And obviously, if there is a reason that you need to stay, then you stay.
Right.
Like if you have a bad heart problem or a lung problem or whatever,
Mm-hmm.
the anesthetist and the team, the surgeon included, decides, hey, we think it's not safe for this person to go home, so then you
Yeah.
stay. So there is that capacity as well.
Definitely.
It's just
definitely.
becoming
and
progressively more
and that decision can be made after your surgery. You could be planning
That's
to go
right.
home after the surgery for some reason.
Wait a second, you don't get the surgery. Like, sorry, Paul, you agreed to go
That's it.
home. It looks like you're having
That's
a lot
it.
of problems here.
Sorry.
Too bad.
That's it. No, no, it's not that
not
way.
like that.
No, like one thing we see often is severe sleep apnea. Some
Yes.
people have really bad sleep
Maybe
apnea.
undiagnosed even.
Yeah, and it's discovered in the OR when you're
Yeah.
sleeping. We're like, whoa, this person's not breathing when they sleep.
Right.
Because even though you're having a regional anesthetic, you're still giving some medication to help you
You're
be
relaxed,
sleepy,
you're sedated.
relax.
Yeah.
And then sometimes we discover things on the ECG, on the heart monitor. They
Right.
say, no, this person should come in overnight. So that does happen.
No,
But
that's
at the
good.
end of the day, it's been shown to be just as safe as staying in.
And I know, and it's amazing. It really is amazing. And sometimes I see my patients in that same day, and you're like, I just can't even believe it. You're up walking around.
Yeah.
They have civilian clothes on. They got their bag. Like, hey, see you, doc. See you at the 2-week
like
follow-up.
nothing happened.
Like nothing happened. Now you know all about day surgery and that it actually is a good, viable option for the vast majority of people. If you like this video, please like and subscribe to our channel.
Remember, it's good for the system. It's good for the patients.
People helping people.
Remember, holy shirts and pants. You are in charge of your own health.
We'll see you next time.